Hello, everyone. Good afternoon. My name is Imani Ransby, and I am a staff epidemiologist with USET and the SAMHSA team. I just want to say welcome to everyone, and I hope you're having a wonderful afternoon. Thank you for joining us today for our RPMS EHR training. Today, we do have a special speaker, James Spillane, who will be covering some information again on the EHR side of RPMS. He is a wealth of knowledge, and we are very excited to have him here today. So please feel free to drop any questions or comments you have in the chat as we go, because I know we are a small group today. And we will go ahead and get started.
All right. Can you guys hear me? Okay, I'm having a little bit of internet connectivity issues, just to let you know. A couple prefaces here. I have COVID right now, so my voice is a little raspy. I'm so sorry about that. I have not been up all night smoking or something like that. It's literally just me coughing and coughing and coughing. It looks like for the most part in the room, looks like we have someone in the waiting room. All right. Who here is like an end user using RPMS EHR like kind of every day, or is this more of a recording that we're going to be doing for future use and stuff like that? Because I'm just curious real quick, because I want to ask a couple of questions. All right. So Dr. Brown, all right, good to see you. All right. Well, and a lot of this might not be new to you guys then, but I'm just going to talk about a couple of things. And I'm going to go through a slide presentation, then hopefully we can go log in and do some stuff in the EHR. It's a little bit hard though, because you have to find the right servers to do it on and stuff like that. And sometimes they're not working because you don't want to be releasing patients' information and stuff like that. So hopefully I can get into this terminal server that has a demo server on it, and I can get into it, which is a little complicated, and we can kind of go through some live examples and stuff like that. All right, so let me see if I can start by sharing my screen and going over some of what I use every day. So let's get in here. All right, hopefully you guys can see my screen. All right, I just got to move the pictures. All right, are you able to see my screen, guys? All right, perfect. All right, my name is James Spillane. I'm an improvement advisor originally from Kodiak, Alaska, and now I live here in Anchorage, Alaska. And what you're seeing here is a picture of Kodiak, and you see that it is kind of rural care. But what is interesting about some of the villages here in Kodiak is they have 5 native villages, and they're very extremely rural. You can only get to them by seaplane, airplane, or sometimes boat, and even that sometimes. And they kind of have a hub called Kodiak Area Native Association in the small town of Kodiak. Well, these guys were really kind of one of the first sites in the nation, like back in 2007 or 2009, that met every single one of their GIPR measures. And they did it using the exact same tools that we use today. And it's amazing that they used when EHR came out, and then we started to have Moonwalk, and we started to have these other things like eye care. They were able to put it all together, all the pieces of the puzzle, identify who needed what, and then attack that solution and meet all of their measures. So they could quickly go in and say, well, show me all the people who need a tobacco education on tobacco quit. Show me all the people who need a diabetic eye exam. And then they would methodically go through, call these people up, and arrange for them to get diabetic eye exams or give them education or whatnot. So I'm going to talk a little bit about some of these strategies, and then some of these basic, baseline reports that you could run to have an idea exactly where your system's at. So I'm going to take a look at some of these. So as you see here, I've been doing this for quite a while. So I just want everyone, I just want you guys to know that I'm not blowing smoke here. I've done this before. I've been all over the country working with tribes. There's tribes here. There's Pequot right there, up in the top right, in Mystic. So I've worked with tribes in the USET, worked with tribes in Portland. I'm working in the Southwest a lot, working in Montana a lot, working in Michigan a lot. So I get to go around working with people on how to use these tools and how to configure your care teams to better improve. So it's a mix of between like, here's the tool, and it's at the end of the day, it's just a tool. And then here's how we're going to adapt, our patient-centered medical home, like who does what, to actually try and make these two come together. When we talk about coming together, a system's a system, right? It's complex. We're all in highly complex systems, and we're in highly complex systems that are never changing. So it's never going to stop. We're never going to have a new thing. We're never going to stop changing. We're never going to be hiring a new, we're always going to be hiring a new person. We're always going to be like adapting. And that's just the name of the game now. And that's the way it is. There's no system that you can, the word robust no longer works, meaning you don't just set it up and it's robust. It's this constant innovation that we live in. And we're constantly adapting, whether it's a new grant or it's a new, a new measure that we have to meet. We're always trying to figure it out. And we have to do that at a system level. So the whole thing has to gel together. So this is kind of, the care model for Indian Health. And the reason I like to point this slide out is you'll also see it, especially like, Dr. Brown or somebody, is you'll have a doctor come in from the outside and they'll say weird things like, well, in the real world, well, that's very, very, to me, condescending, or I ran my own private practice or something. It's like, no. We have this whole thing that we're charged with, and we do a holistic approach, and we do holistic care, mind, body, spirit, the whole works. We're not just a triage center or urgent care clinic where you come in with a sprained ankle and we send you out the door with a fixed sprained ankle. It's not that, it's everything, mind, body, and spirit. So you kind of got to look at all this as like a whole entire system. So when you are looking for your reports and stuff like that, or data extraction, you want to get a big picture and then try to like drill down to what can we change kind of stuff. So a lot of what we look at when we're doing this and we're thinking about this is, all right, is it going to better the quality of care that we're giving our patients? Is it going to better the health of the population? The other thing is it going to be a good experience? I'm sure we could meet every single measure if we ran it like, a gulag in Russia or something like that, where we would be like, you're a patient and you walk in the door, or like you're in the military and we're like, you need to get this, this, and this, no ifs, ands, or buts. And, yeah, you'd have really compliant patients, but do you think their experience, customer service would be great? No, they would hate it, right? So you have to have a nice balance of, hey, can we ramp these things up, and can the patients really get on board with what we're doing and want to be a part of it and really want that care? And then finally is like per capita cost. So, and this is also, wasteful thing, reducing waste that's inherent in our system. So we, healthcare as a whole has a tremendous amount of waste. So you're constantly looking at like, all right, is this necessary? Do we need to do this? Is this paying off? Is this productive? Is this a good, thing to be spending our money on? And if you kind of put all those together, you have a good approach, and you have a good solution to what you're doing. So when I'm thinking about my reports and I'm thinking of all these things, I kind of pull them all together into this kind of backdrop. So here's that change package that we were talking about the last time I was on here. And this has been around for years. And sorry, I got to drink some water. But, a lot of times, and I just want to point this out, we think of the EHR as like the whole thing. We think of it as like the easy button to, oh, well, we'll just get a new EHR, it'll solve all of our problems. It's not even anywhere near that. That's just one thing and a factor of many. And so one of the first things that they lead off with here is do you have engagement from the leadership? Is this an organizationally willful, leadership willful, change that we want to make, an aim that we are going for? So in that left column is you kind of have the basics, and the reason, we're talking about reports, right? We're talking about analyzing your system. We're talking about, where are we? What do we need to do? Let me know if I go out on you, because I keep getting this internet unstable thing pop up. But part of that is the assessment. And so even in this first phase, you got to know where you're at. There's this great quote, basically says, it says something like, if you aren't measuring, you don't know and you don't care. So if you aren't measuring, you don't know and you don't care. So, and I can tell an improvement organization simply because when you go to them, they know. You can say, how many diabetics do you have? And they'll be like, oh, 242. They'll know because they're constantly on top of where they're at. So that's what we want to get as organizations, is to constantly be on top of, like, what's your user pop? 2,400 patients. Okay, great. How many diabetics do you have? How many active insurances do you have? Your payer mix. These are things that a good organization knows, all these little working parts. So when they get together and they make decisions, they already have the big picture. And that's kind of what we're going to give you a little bit of today, folks, is we're going to go in and we're going to pull up these quick, easy reports that can quickly give you a broad's eye view of how we're doing as an organization. So there they are. You have the column 1, and then you have column 2, and you'll see that, it's clinical information is just a little small thing in here. But we talk about the care team and paneling the patients. Care team and design really is what that is. And then eventually when you learn stuff, you move it, you spread it throughout the rest of the organization. So I'll go into some of these reports. So, that was supposed to be first. All right, so I was just going to talk about, there's literally too many reports for me to go over today to show you guys that are all useful to me, and I use them all. So I have to kind of think about, well, what do I use in daily? What do I use weekly? What do I use when I walk into an organization and they're asking me what's wrong, and I have to start to try and come up with solutions and figure out what the sore points are. These are the kind of reports that I would run, and I'm going to get into that in a sec. But just to let you know, pretty much every package in RPMS actually has its own reporting function. So you can go into UDS, you can go into CRS, which is GIPRA. You could go into your practice description, which is looking at the clinics and seeing how they're doing. You can create your own Q-Man reports that have unlimited amounts of different reports you can do in there. Your visit generation, your patient generation, DGen, PGen, these have all these reporting capabilities. Moonwalk BMW, they have reports. What's my third next available appointment look like for this clinic? So you can measure supply and demand. You could also go into Moonwalk, and look at what is the continuity of care? How many of my patients are actually coming to see me? Is it greater than 60%? If it's not, I might want to start to wonder where my patients are going. We can go into third-party billing. We can do aging reports. How well are we billing out? It is literally unlimited, especially if you get in there and you start messing around, you start learning how to use these things. And by the way, they all have user manuals. So if anyone's interested, you can go to ihs.gov, you can find the user manuals, and you can learn how to do these reports. It's just going to be a matter of access and keys for most of the people out there. But a lot of what I learned was just that. I would go find the manual, and then I would go look at the manual and then try and run my own report and then kind of figure out where we're at. So a lot of it is self-taught. You can self-teach in here. Or you can have call up somebody like me and I can walk you through it. So here are the main ones, I kind of use pretty much all the time. So the first one, it's basically looking at a clinic, not necessarily a provider, but a clinic, because a clinic can have multiple providers operating it. But for the most part in Indian country, we'll name a clinic after the provider, and that's kind of like their clinic, right? So that's looking at like, this report's really good. And we in the background, we just call it PPDS. So it's like a practice profile description of how well that clinic is doing. And it shows you like workload numbers, but it also shows you like what are the top 10 POVs, what are the top 10 medications that provider has prescribed, what are the top 10 medications, what are the top 10 E&M codes, what are the, you know, a really good idea of like how we are functioning. And you can quickly look in there and you start to see here are the top POVs and here are the top medications. This seems to be the area of focus that we probably want to look at, you know, as an entity or an organization. The GIPR dashboard, and you kind of get a little bonus here. We're talking about GIPR dashboard, patient lists, and forecast. So in the clinical reporting system, CRS, you have all these great reports you could run. The dashboard's the most important. That's what you send, you know, to area office, and that's what you send off to, you know, the data warehouse and stuff like that. That's your GIPR numbers. That's your numerator, denominator percentage of how well you've done on all of those measures that you have. This is a great report because I think GIPR in general is a great report because it's a good multiple domains, right? So if you really want to know how your organization is doing, this is covering all of the main markers, right? Diabetes, behavioral health, immunization, sexually transmitted diseases, cancers, all these kind of things are all bundled up in there. So if you want to really get an idea of how an organization is performing, run the dashboard and you'll get that idea pretty quickly. Thirdly is national aggregated. So that's in iCare, and that's a tab in iCare. And again, that's numerator, denominator, but unlike the GIPR year, where it starts in October, this is looking at from today backwards. So today backwards 365 per se. So as of now, live data, how are we doing? We're not starting over fresh in October. This is just right now constantly going, right? So iCare is really good at this, and iCare is a really, well, it's literally one of the most powerful tools we have at our disposal, and it's been. And if you utilize it correctly, your organization will be, you know, award-winning, if you will. So we're going to talk a little about that. So what I like to do with iCare and National Aggregated is I like to say, show me the user pop. So I want to get an idea of the whole entire user population. And then I go there and I can tell quickly what's red and what's green. So I'll show you kind of what that looks like. Provider report cards. You know, this is not necessarily a bad thing. You know, it's not people kind of shy away with that word report card. But what you're really doing is you're looking at a clinic. So again, sometimes there'd be multiple different providers in a clinic. But you're looking at a clinic and you're looking at how that clinic's doing. So you can say, you know, one of the ways you could run this is you can say, show me all the patients that are assigned to this person as a primary care provider and how well are we taking care of that panel. Care management. So this is in iCare and this is a tab in iCare. And this is incredibly helpful, particularly over like the last 10 years when they came out with these new functions. It was really great because what they did is they threw in the whole entire diabetes audit right into it. So before the diabetes audit, you know, finding out who was due for what was a kind of a pain in the butt. Now I can literally say, show me all my diabetic patients. And then I hit the diabetes audit and it'll show me who needs what. So right now I can manage my whole entire diabetic population just in one place, one-stop shopping. So that's why this is a really powerful tool. And then of course, COVID came out. So I got a whole bunch of calls in the beginning when COVID came out because people wanted to identify their high-risk populations. So we didn't even know what's high risk, and it was changing kind of every day with the CDC and everybody else. And you know, as we learned more information, this became high risk, and then this became high risk, and then it kind of zeroed in like, you know, this age range with these comorbidities, with, you know, and then those comorbidities, there was everything pretty much was on there. So I would have to manually create these things to kind of get a list of these are the people we're going to call up first when we get the vaccination. Then they just came out with they came out in eye care with this, and it was great. You could just literally go in and then hit COVID and then just hit high, you just see all the ones that are high risk, it just checked it off for you. And then you're like, okay, these are the folks we need to call up and get them in and let them know that we have a vaccination ready for them. So this is that's all great. And then finally, this would be, a bonus, how we can use these tools to forecast and look at who's coming into our clinic, right? Who is coming in tomorrow? Who is coming in next week? Before they get here, we're chart reviewed, we understand what they're due for, and we're ready for them. So even though they're coming in for an earache, even though they're coming in for a cold, or a cough or a raspy throat like I have, we know that they're due for a PAP. We know that they are due for an A1C, so we are going to be prepared to give those to them when they arrive. So we will be prepped and we will be ready. And that is what, if you went back to that care model, prepared care team, prepared patient, that's what we would be doing. So we're going to take a look at some of these. And so we'll look at first the screenshots of them, and then we'll see if we can actually get into them. And that's going to be a little harder, like I said, because I have to remote into a demo server that's on a terminal server, which is hard to get into. So we'll hopefully get there so we can give some live demonstrations. But if not, I want everyone to know that I will be more than happy to reach out to anyone one-on-one and do this, because I absolutely love this stuff, and I love showing people how to use it and how it can, seeing the light bulbs go off. All right, so this first one, let me move my pictures around here so I can actually see what I'm looking at. This is that first one, remember, we call PPDS, right? So in RPMS, you can literally just go UPAT PPDS, and then it will jump you to provider practice description. And so what we're doing is these numbers are going to be all over the place, because sometimes when you do these like demo servers, it doesn't pick up all the screens. So these aren't like real numbers, but they're close enough to kind of give you an idea of what they look like and how to get there. But I just needed to show you guys kind of what this report looks like. So it's not easy on the eyes in RPMS. We all know that, you kind of want to make these things prettier, make them into graphs and stuff. But we're looking at a primary care panel. So you have number one, then you have number two, demographics workload. So this is giving you all sorts of valuable data, how they're broken down, male versus female, how many are on your panel, how many aren't on your panel, where are they coming from? So this whole area, this is Montana. Dr. Brown was there, I believe, in Montana, so he might know a little bit about this area. And then number three at the bottom, this one is really important, but this gives us our ambulatory workload. So I can see that clinic has had 1,624 ambulatory visits during that time. And then that provider was the primary on at least 1,200 of those visits. So that's a big number that I can grab. If I was to actually scroll down, you'll see what are the top purposes of visits, what are the top medications, what are the top E&M codes. So you could see like complexity codes. These are very important. So sometimes you'll see a provider will have, maybe they don't have a low workload, but they're seeing very complex internal medicine patients, very multiple comorbidity patients. So yeah, they take a little longer. So they aren't seeing as many, but they're doing a lot more complexity and billing out at a higher rate. All right, this is that GIPRA dashboard. So, sorry. Again, this is like, you got to be doing this. You got to be doing this at least weekly at your site. And there's a GUI that you can do it. That's a lot easier. So there's a graphical user interface that you guys should be using. That's a lot easier. But here's a GIPRA report. This would be like a couple years old or something. And this is just an example of what it looks like. So I take these and I print them up on like a text thing, and I manipulate the data a little bit so I can, have something to point out. These guys are not bad at all. They're actually pretty good. But these numbers I wanted to point out, just so you guys can kind of take a look. You can kind of come in and again, like when you run these reports off of like the demo servers, it doesn't pick up half the stuff. But if you run it in actually production, these guys it's picking it all up, and they're actually doing pretty good. So we can quickly see in here, like you look at like nephropathy, the national target is 45%, and then you look at where they're at, 2.4. So they've had like 118 people come in, but they've only completed it on 3 of the people, supposedly. So again, this was telling you like, oh, so if I was working with a place like this, I would say, all right, we need to get better at GFRs. We need to get better at these other things. So coming in here, kind of purposely lowering all the numbers so you could see like where are the trouble spots we need to look at. These would be some of those trouble spots. So a lot of sites don't have dental, but it is also telling you here how many patients you need to do it. Sorry. So the great thing about this report is, let's say you're trying to target in on a measure and you're doing tobacco cessation counseling at the bottom. So this site's like, you know what, we just need a couple of more. We just need 5 more to achieve this target. So that's what's really good about these tools, is they tell you how many more you need, and then you can take it to the next level. So what you could do is you could run a list. Okay, so when I look at that tobacco cessation, I went in and manipulated a little bit, so it looks like we only need 5, right? So now we only need 5 on these guys, right? So we're going to go in to try to replicate what it would look like in production. And so now we have something where we can say, all right, let's go into CRS, and we're going to flat out search by list. So that's that CRS list report. So I'm going to target now, so I can look at the dashboard, see that tobacco quit is real close, and now I'm going to target tobacco quit. So I'm going to come in and I'm going to select it. So number 19 here is selected, and then I'm going to come in and I'm going to say number 2. You get the little Gipper brackets on the right hand side, that kind of helps you out. But I'm going to select number 2. I want to know all the tobacco users who do not have that intervention and who have not quit in the last reporting period. So this is going to give me a list of names of the patients who I need to call up and talk to them about, hey, just to let you know, we have services for you. We can, if you need any, we got everything for you needed. You shouldn't smoke, by the way. So healthcare in general, you can't go to your provider, or you can't say I drink or I smoke and then not going to talk to you. You just say, that you shouldn't do that. This is, you should cut back on your drinking. You should try to cut back on your smoking. They're not going to say, keep going, So we know we're doing it. We just got to annotate it better. And that's what that last talk was about, is where do we capture these things? Now I'm showing you how to find them. So then what we have is a list. So right here, you have a list of all the patients, and you can see when they were identified as a tobacco user, what type of tobacco user, and these are the ones that we need to call up, and these are the ones that we need to get into our clinic, or we need to target when they're coming through our clinic as an opportunity and give them that tobacco cessation education. All right, here is another very, very useful tool. We use this up at Manilic, and this is in the CRS package, the clinical reporting system. So, or, like what we like to say, GIPRA, and this is the forecaster. So what the forecaster does is it goes in and it's looking for your schedule of that week, and it's telling you at 7:15 a.m. demo Jill, or Jill demo, is going to come in, and these are the things that she is due for. She is due for an influenza. She is due for an age-appropriate, immunizations. She's due for cervical cancer screen and an alcohol screen. So what before the patient even comes in, you could run these reports and, kind of have a nurse huddle, and you guys can basically say, highlight these things that you want to address. And as they come in, you can address them. So not only is your EHR already telling you this with clinical reminders, but we could be preactive the night before or the week before, and we can look at schedules and we can say, show me, on Tuesday, what are all the people due for? And this will actually tell you before they get there. So really, there's no excuse if we're not doing good, right? We really should be doing better. All right, this next one I really like, excuse me, I really like to do is when I want to get the quick picture of how well an organization is doing, I will do the active population. Like, you could call it user pop, you could call it active pop, but I basically just look for anyone who has had 2 visits to pretty much any clinic in the last 3 years. Those are the people that are kind of getting healthcare. Maybe they haven't moved. They are going to the University of Florida. They are, they're in our community, and we just want to see how well we're doing on those patients. Are we taking care of them? Do we need to get them back in for something? So I'll just go into eye care, and I'll go on the left-hand side. You can see I'm selecting an ad hoc search. Then on the right, there's filters: patient, PCC, problem, POV, reminder, visit. All right, I'll do visit related because that's where that'll be. I'll select time frame, last 3 years, and then I'll go to edit down here, edit, and I'll say greater than or equal to 2 visits. So they hit our system twice in the last 3 years. All right, so now let's go along, and this is kind of what it looks like. So I'm going to move always trying to get rid of the videos. So what I'll do is I'll come into here. I'll quickly go to national aggregated, and then I'll look at it and I'll sort for, on the left-hand category, national GIPRA. So at a glance, anyone, just tell me something that these folks might need to work on. Just looking at it, what would you say we need to get better at?
Just depression screening in adolescents.
Exactly, right? So we got really good at asking adults, are you depressed? But now we have to realize, oh yeah, kids get depressed, especially when you're older like me, and you got sore bones and you got sore and your hair is turning gray and you're getting older and older and you can't run as fast as you used to run. You don't think a youthful person will be depressed, but we do have childhood depression and we do have suicide. So we have to get better at checking these things. So what happens as these measures come out? We get really good at like asking everybody, do they smoke? Then the secondary measure will come out. Well, now you have to tell them you have to quit smoking. And we take a little while to adapt in Indian country. So we get good at asking the depression screen. Then all of a sudden they say, now we want you to ask kids. And it takes us a little while to kind of turn that ship around and ask these. But the point of national aggregated, the point of this dashboard, if you will, is you can go into your own organization, you can quickly pull this up, and you can see in red what needs to be addressed very quickly. And that's why I like using the demo ones on these, because there's a lot more red. Some sites you go to, it's all green and you can't point out anything. But there you go. All right, so next is like if I'm managing my own clinic and I wanted to know how I'm doing. See if I can move this back. Sorry. Go back up. So what I'm gonna do is I'm gonna run I'm gonna quickly go in here and I'm gonna run for my patients who are coming in next week. Hold on, there is where I wanted to be. Sorry. So what I'm gonna do is I'm gonna create my own panel first. So I'm gonna come in and it's gonna, so I can do how I did it on the whole population. I can also do it just on my patient center panel to me. So if I'm a provider, I'm going to start to want to make sure that, hey, maybe I'm doing pretty good. My panel, nobody can point the finger at me. My panel is well managed and I'm doing pretty good. And then I'm going to go to that national aggregated to kind of see where I need to focus my team in the right direction or in the positive direction. So what I'm going to do is go in here and I'll just call this one Stacy. And I'm going to pick my provider. So on the left-hand side, you see how it says patients assigned to. So that's going to be pulling up primary care providers. And I'm going to pick the provider name. And then I'm going to do a designated primary care provider box. I'm going to select that. And then I'm going to hit OK. And what this will do is allow me to look at that same thing, national aggregated, but where do I need to focus? So this is why empaneling patients in the patient-centered medical home model is so important, because we get a little more accountability, but we also get a little bit easier to manage because we know, all right, here's our patients. It's not just a free-for-all. These are the ones that we can actually address, and we can, better our healthcare. So the third one we really like to do is come in and identify and create a panel for our patients who are coming in next week, so we can see what they're due for before they even get there. You can also do this for tomorrow. So at like San Carlos and places like that, they have this set up for tomorrow, and all the MAs literally go through and chart review all the patients that are in the schedule for tomorrow. So they'll be seeing they see about 15 to 20 patients a day. They already know before they get in here. They have these things called half sheets that they write on, and they basically say this patient's due for this, this, and this, little triage sheets, if you will. And so when the provider gets that, the provider knows what they need to address when they enter the room. So real quickly, you would go in, you would do time frame next week. I just did it for next week so we could get more patients. I had to go plug in all these patients too to do it. And then by scheduling clinic, and then you pick the scheduling provider or whatever, and then you go take a look at that. So one of the things, if I'm going to create one of these, I'm going to want it to do me a favor. I don't want to look at all of the measures necessarily of what every single thing that they're due for, but I'm going to want a couple of things on that. So in eye care, I can change the layout. So I created my panel for next week, and now maybe we're in cancer awareness, breast cancer awareness month, November or whatever. Maybe we're focusing on, just cancer per se. So I'm going to create a new list. I'm going to create a new layout, if you will. And what I'm going to do is go in, and I got my patients that are coming in next week. And then what I'm going to do is add mammo, pap, and colo. And then I'm going to add next visit appointment, date, and time. And for a bonus, just to show you guys, we have active insurance coverage. So if you ever wanted to find out what your insurance mix is, or your payer mix, as we say, you can go create one for your active patient population like I did before. And then I can add that insurance, and I can quickly see that we're a 50-50, like 50% of our patients are on Medicaid, but 50% of them have insurance. So that kind of tells me we're not getting that encounter rate on every single patient. We also need to make sure we're detailing very well and documenting very well, because 50% of that is active insurance, and we're billing out, and they're going to be looking for that documentation in order to reimburse. So this is just another little tool that we can add that is very useful, and I get asked to look at a lot. But the cool thing about adding next appointment date and time is once I get that list, for tomorrow or for next week, I can stack it chronologically. So this person's coming in first, this person's coming in second, this person's coming in third. So that's kind of what it looks like. So what you have here is you have colon cancer screening, you have mammo, you have pap, you have their insurances, and then you have their next visit date and time. And if you noticed, they are kind of stacked. So July 27th at 8 a.m., and then August 1st at 7:15, and then at 9 a.m. So I can see when these patients are coming in, and now I got these red no's, right? So I know on August 1st at 7:15, I'm gonna have to, there's the patient that is coming in is due for a cervical cancer screening. So I already know, I'm prepped for it, I'm ready for it. So when they come there, we can ask them if they would like this or not. And then kind of finally, I just wanted to show you in eye care, that tool I was talking about earlier. We can go into care management tab. So we have up here the national aggregated, the national measures. We already have gone in there. We looked at the national measures and we looked at like, what do they do for its individual patients, right? The national aggregated is a numerator or denominator, so you're getting a percentage, so you can quickly look at the whole organization. And now we're in care management. So in care management, I can pull either from a QMan registry, so I can pull like, show me my diabetics. I can say, show me everyone who has diabetes on their problem list, or show me everybody who has a diagnostic tag of diabetes. Multiple ways I can get my diabetic patients, right? And then I can go into here, care management tab, and I can hit diabetes audit, and it will literally give me the diabetes audit right in front of my eyes. And I can say, oh, that person needs an eye exam. That person hasn't had a depression screen. That person hasn't had a foot exam. So we can quickly schedule, like we'll utilize these a lot for like our DM clinics up here. So we'll do like a diabetes week where we have specialists come to site. You got the dentist come, the foot doctor come, the eye doctor come. You got all these specialists come for a week, and we try to schedule all our diabetic patients. We use this right here to kind of identify who needs what, get them into our clinic and get their needs met. The other thing is on here, you see you have asthma, COPD, Hep C. We use this a lot with Jessica Leston, and those guys will come in, Brig Riley and us, and kind of use the Hep C one. HIV, same thing with the STD folks. But COVID, right here, you can look at your population, see who's had what shot, who needs a new shot, and I can sort for high risk, and I now have a target market that I can address. So, when they come out with the youth ones, I quickly go in here and I use this COVID one to identify all the youth, or the high risks, or I can quickly identify who has not had this, where have they got it. Maybe I want to go on to my state registry and find out if they've had someplace else, things like that. So this is an incredibly powerful tool. All right, so this is left over from the last one. Sorry about that. Yeah, so I got a couple of questions. So I'm kind of at the end of my presentation. So I'm going to see what's in here. It says the sound quality has been okay so far. All right, good. Is there any way to get reports that we have built in roll and scroll in EH or ERH or BHS? So, all right, yeah, there are. So in eye care, one of the things that you can do is go in, and on the left, when you pull up a new search, on the left-hand side, there's one called registries. So any registry that you've already built, that you already have, like a diabetes registry, immunization registry, or anything like that, we can pull those into eye care, and it'll be nice and pretty, right? You can also do QMan. So any kind of template that you've already created, and you get to a point where you name it. So if you can name your report, most likely you can pull it in, and you go to QMan button, find that report name in the drop down, and then you can pull that in to eye care. Okay, so now I'm kind of like at the end of the presentation. Right now, for a quick moment, is a good time to like quickly go to the bathroom, quickly grab a drink of water. And also, if anyone has any questions, please feel free, because we're gonna try to log into it, remote into a server, and we're gonna try and do some reports real quick so I can show you where they live and what they look like. So does anyone have any requests, wants, questions, needs, anything? Nothing? You guys are always so quiet. I'm gonna have to like get some like implant some hecklers or something. So, all right.
I have one question. Are there any restrictions, or can anyone with RPMS access these types of reports? Because I have RPMS access, but I have never seen like the tab, I guess, formulation that you were showing, but I'm familiar with like the menu items and going through that way.
Yeah. Yeah. So a lot of what we're doing here, really, honestly, in this presentation is just kind of pulling the curtain back, if you will, and, exposing the wizard. We're pulling the curtain back and we're saying, like, this is all the stuff we could do with this tool. And then once people start to realize, hey, I've never seen that before. How do so you start to get curious, right? And now that you know that it can be done and how this machine can function at a higher level, and what it really can do to serve you, you start to get curious and you start to go down that rabbit hole. So you start to go, well, let me go on to ihs.gov and type in RPMS, and let me go find that package and see if I can get the user manual on it and see if I can look it up and learn it. And then the next thing is you're like, hey, I don't have access to this. Hey, where could I go for some one-on-one training so I can get access and I can start utilizing this report? So this is really just the tip of the iceberg for more. And so hopefully what we do is we show you this stuff, and then you come back and you say, hey, can you show me where this is? And can you show me how to get there? What do I need to have access to this? Do I need to request to my CAC that I have this menu item or this special key to run this report? What you're also doing is saying, hey, this is what I do for work. I need access to that. I need to know how many diabetics we have. I need to report on this. My grant is, dependent on this. So what we're doing is kind of showing you some of this stuff for the first time, maybe, and then you start to say, you dig deeper, and we dig deeper into it. So, and so how many, has everyone seen this before, or is this all kind of new to you guys? Just real quick. And then Dr. Brown's asking for a moonwalk demonstration.
Yeah. Hi, Jim.
Hey.
Sorry, long time no see.
Yeah.
Sorry to hear you have COVID. I hope you recover very quickly and without any complications. Sounds like you're doing pretty well, though, if you can talk for this long without coughing a lot and stuff. But yeah, I'm familiar with most of these from a long time ago. One thing that I have never really seen much of or had any experience with is Moonwalk. And I don't really do outpatient medicine anymore. I only do inpatient. How did Moonwalk get its name? I mean, do you know where the name came from? I've always been intrigued by that.
No, I don't, but Chris Lamer will. Chris Lamer probably knows where the name came from. So if you hit him up, he was kind of managing it for OIT at that time.
Okay.
So he was working with like Imran and the other guy who, worked at Pyran and came out with it. So, so he probably has the history behind that. And of course, BMW is the package name. So in the background. So, yeah, so in Moonwalk, Moonwalk's basically is a scheduler. So it has schedules, but down at the bottom, it actually has reports, and they're pretty intuitive. You can go into report, and then you could say, I want like a workload report. So it's all at the bottom. So if you have Moonwalk and you can get into it, you go down to the bottom, there's a thing called reports, click on it, and then it'll give you multiple different reports. I'll kind of show you what they look like if I could log in here. So let me see if I can get out of here first. So I'm trying to escape. I'll shut this down, then I'll see if I can log into a remote server. And I'll see if I can find Moonwalk in here. You gotta bear with me a little bit. Okay. All right. I'm trying to, there's a lot of latency here, sorry. And so for those of you who haven't seen this before, this is kind of like the scheduling package. So just trying to log in here. All right, so when you come in, it's kind of like a blank canvas. So that's kind of what we're looking at right now. So the cool thing about Moonwalk is what it did was it kind of took a couple of things like our patient registration, which was a separate package over here, and our scheduling package over here, which was separate, and it kind of combined them into one place. Because if you think about it, you're registering a patient, you're probably also going to schedule them, right? That's the whole point of them being here. Hey, I want to get help. You're going to register them, put all their insurance information in, their addresses, their telephone numbers, and then you're probably going to schedule them for an appointment. So that's kind of how that works. So down here is what I was talking about with the reports. So on the bottom, it gives you these kind of canned reports, if you will. And I can do a couple of things in here. At the top is the ADT. So that might be something that you want to work with and play with. And I will be totally happy to do some one-on-one time with you and kind of show you that. Fortunately, none of these guys have hospitals or anything like that. But you can go in and do like admission reports, admission discharge reports, range of dates for inpatient services report, a monthly report on inpatient. Like even just here, this would be a good place for you just to toy around. And oh, by the way, you can't wreck anything. So this is totally safe. So you can go in here, say, go to reports in Moonwalk BMW, and then just start playing around with it, you know, and see, oh, what do I get if I do this? What do I get if I do that? There's those registrations. So prior authorizations report, insurance enrollment report, workload report. That's pretty good. We use the bottom one a ton. So scheduling reports. So I want to know by clinic, how well are we doing? What does our workload look like? Third next available appointments report. That allows us to monitor access to our clinics. So what that's doing, it's a weird way they do it, but this is the way that works, right? You pretend you're a patient walking in. You don't look at the next available appointment or the one after that. You're looking at the third one. When is the third opening? And you kind of want to keep that close to like the week. When it starts pushing out further than a week or two, I already know that we have an access, supply and demand issue. So I run that report and I try to keep it like if I'm a patient walking in, I can at least get in tomorrow, right? For an appointment kind of thing. Cancel no-shows report. This is really good because that kind of shows us like, you know, how many people, what's our no-show rate? This is really at the end of the day, guys, what you want to do is you want to have a dashboard or like a system that's like, here's our workloads, here's our no-show rates, here's our GIPRA quality measures. You want to have multiple measures on, you know, some kind of metric dashboard that the team can look at and see like, oh yeah, well, our no-shows are going up, or, you know, why is our PAPs and mammos going down? Why is, you know, they can look at this thing as a dashboard. So a lot of organizations will ask me to actually build that for them. And then I show them how to run these reports or automate these reports. And that way they have them at like every weekly meeting. And that's where we want to get to as an organization. This is what you guys want to be doing. You want that data in front of you so you can make informed decisions. Yeah, the waiting list. So if you create a report if you have a waiting list, you can actually put people on waiting lists. So that way you can quickly call them and get them in if they want to get in for something. Lots of good reports in here. So do you see that, Dr. Brown? Does that look like something you can play with?
Yeah, I mean, as I said, it's great being semi-retired and no longer having much in the way of administrative responsibility, but I still enjoy, looking at population health kind of data. And I did not realize that Moonwalk had the inpatient component to it, so that's nice. We do have 2 facilities that have inpatient units here in our area, so that part's useful to me anyway. But yeah, the rest of it certainly looks like it's pretty useful, especially to people who are quality assurance, quality improvement is part of their job description, which actually it should be for most of us, I think.
Exactly. Yeah. So, and I don't know how many people are in quality assurance. Sorry, I got a dog that needs to be let in. That's the problem when you're working from home. You got dogs, cats, and kids. So, yeah, you guys get a little tour of my place here. All right, so let me bounce out of Moonwalk real quick, and I'll kind of show you some of the functionality on some of the other stuff that we were talking about. I think if I close that one, I should be pretty good. Okay, so I'll kind of show you in the back end, the RPMS roll and scroll world, really quickly what some of these reports look like. And then what I'll do is of course the dog's licking its water now. Then what I'll do is kind of show you in eye care how to, like, what some of these look like. So you can get a kind of idea. I don't want to jump in too much. We have this is like scrambled data, but I don't really like it 100% because what it has is, it has it takes the patient's name, it takes their last name, scrambles them all up, right? And then it takes the numbers of their charts and scrambles them all up, but it's still weird because it still is like someone's last name. And I don't like that. I just feel a little cringy with that because it's like, you could a lot of our places are so small that there's only a couple of families there with that last name. So you can kind of, it's like, oh, so I don't want to do that. So I'm going to try and be very easy with this. So I'm going to log into a remote terminal demo server. And then I'm going to kind of, all right. So I'm going to see if I can back out of here real quick. So when I log in, I get a whole bunch of googly gook, right? And so it's really cool to know these kind of jump screens. And this is also a quick way to find out, do I have access to that or not? So the main one at quality reporting that we do is that CRS, right? Clinical Reporting System. That's GIPRA. So everybody should know what it is, and few people should have access to it, but I'll just show you how I get there. I normally just go Shift-6, CRS, and I jump right in and saying, all right, James, do you want last year's or this year's? Well, I'll do this year's. CI22. And then, how, I know this might be very hard to see. I'm really apologize for you guys. But every one of these packages has like a report menu. So that's what I'm going to look at right here. I'm going to go RPT, report. And then it's like, hey, do you want to do like a local one? Do you want to look at your taxonomies? What do you want to do? Or a national one? I want to do a national one. And then in here is where we get all the cool stuff. So remember I talked about list, LST. So let's say I wanted a list of, I know that we're only doing 30% of our depression screens, but tell me who is due for a depression screen. That's that list. It's giving you a patient list, literally saying, according to this GIPR year, these are the patients that are due for a depression screen. These are the ones you want to go out and get. Your dashboard, remember that was that one with the numerator denominator and showed you how many more you needed to meet the measure. So that's one that I like to run weekly and give out on a Friday to everybody. So they all have an idea whether we're getting better or worse. And then there's that forecaster, FORD, forecaster. So you pick a date and time, you pick a provider or a clinic, and you say, all right, tomorrow, show me what's the forecast. What are the patients that are coming in? What time are they coming in at, and what do they do for? So almost this menu alone, you can single-handedly meet all your GIPRA measures if you just come up with strategies, just this menu right here. So once a lot of it is not like a lack of will, it's just a lack of knowing that, oh, this is where I need to go and this is how I need to do it. So hopefully this starts turning on some lights for people and they're like, I want that, and how do I get there? Because this is going to make us change the healthcare of our whole community. So that's the first one. I'll kind of show you kind of like what the GIPRA list looks like, for example. So I go LST, and then it's giving you the list. So if I want to know, let's say I want to know how many people need a depression screening, I can go select S24, and now it's got the asterisks. And then I'm going to go, what do I want? I want no documented depression screening 18 and up. So like before, when we look, here's a good example that Dr. Brown pointed out. Before, we noticed that we're doing okay on the 18 and olders, but we're not doing good at the 12 and 17s, right? So if I wanted a list of, oh, wait, well, when we looked at the national aggregated in eye care, it literally said we're doing red and that number. So now what I'm going to do is come back around and I'm going to search for no documented depression screening 17 or 12 to 17, and it's literally going to give me a list of all the patients that are due for that. And then I can go out and target those patients and say, hey, let's call these people up, see how they're doing. So there you go. And that's kind of how you do that one, but I'm not going to run this. So I just want you guys to see what it looks like. The other one was the practice profile. So this is a pretty cool one. So anywhere in here, you can do jumps by doing like a shift 6. So I'm going to jump here. I'm going to go PPDS. Remember I kind of talked about that earlier? So this is like a practice profile. So if I want to take a look at a clinic and how well they're doing, I can get a good snapshot of it. So we'll do, T minus 365 to today. Let me pick a provider. Okay. I'll go for a long version just so you can see what it looks like. And I kind of do this little hack here so I can kind of get it more scrunched together. Otherwise it kind of separates sometimes. So here's the report. So let me go up. So it kind of starts up here. You got like general demographics. You got the, male, female percentages. So you'll normally see a female provider will have maybe more female. A male provider most likely will have more male. You have breakdown of, what tribes are they coming from. So when we're in the production server, I'll go run this report for these guys because they want to know who are we mainly seeing, where are they coming from? Scroll down a little bit more, ambulatory workload. This is the big one, number 3. You can kind of see 1,600 visits.
I think you froze on us, James.
Diabetes, hypertension, these are becoming our leading issues here. Again, sorry. I'm getting locked out of this is what happens when you have a rickety old terminal demo server. I'm not in production, so it doesn't work as well. So I got to kind of reconnect every 5 minutes. So here, let me get out of here. if I can reconnect. But you're kind of seeing some of the stuff that we can do in here. All right, I'm gonna stop sharing real quick. How much more time do we have?
I believe
It's
20 minutes.
scheduled. We have 20 more minutes, I believe.
Okay. But we might be wrapping up here, so it might be going to questions because one, my voice is not almost completely gone. Two, the internet connection is not doing too well. So if we are going to wrap this up, I wouldn't mind looking at like what are some of your guys' questions. Like Dr. Brown had a really good one about moonwalk. Is there anybody else that has any wants, needs, questions? Any follow-up, any kind of stuff that you want me to send you, like a how-to, like if you have any questions on how-tos, any questions about keys, any questions about access, I'd be more than happy to answer any of that stuff for you guys. So let's kind of open it up a little bit. And I know it's mostly not, it's mostly just USET folks, right? We don't really have a lot of the end users on right now. So my theory is that you have a recording that you can give to end users when they need it. So that's my working theory. Dr. Brown, where are you working?
I work for the Eastern Band of Cherokee part-time as a hospitalist.
Oh, nice.
And I'm also an epidemiologist for USET, for the Tribal Epidemiology Center.
Oh, nice. Do you get to work with Brian Hendricks then?
Oh yeah, all the time.
Oh, that's great. That's great. All right.
Yeah, I was telling somebody recently, I may be one of the few, if only, hospitalist epidemiologists in the country. I don't know too many of those. We do have a couple of people, a couple of colleagues from up at St. Regis Mohawk, up in Akwesasne, New York.
Yeah, I've been there.
Have you?
Yeah,
Yeah,
cool.
beautiful place. Yeah.
Uh-oh, I'm losing you guys.
I think his internet's about like mine. Yes, it does, Lindy. I grew up in central New York State, so not too far from you guys. I know how that is up there.
Nice. Yeah, they one of the directors up there, when I was up there, he actually did a study up in Alaska, and it was on prenatals, right? And so we were coming up with strategies for prenatals. You know, sometimes they would deliver early out in the village, and it'd be hard to get them into town in time. So we came up with a whole new protocol where if you live in a very, very rural village, you come to town a month early. And that was started by a guy up at St. Regis Mohawk, or Mohican. So, so a question in the box was about how to get eye care. So eye care, I can give you some how-tos, like on how to create patient due letters. So you can create letters, you know, in advance of who, you know, here's all your patients that are due for colon cancer. Here's all your patients that are due for Pap mammo. And you can do that. Really what you guys are going to want to do is like some one-on-one time eye care training. So the typical IHS eye care training lasts about 3 days, 2 days mainly. And then kind of like the last day is more practical how-to-y stuff. But what I can do is I can do one-on-one with you guys, you know, and, you know, it's, you know, just off the record kind of stuff. We can share screens and I can kind of show you, like, here's your basics on how eye care functions, and I'll show you how to grab your population and how to do that. But I can make the how-tos for you. So if you're interested, just let me know. All right, any other questions? So at an epidemiologist level, what are you seeing, Dr. Brown? Anything jumping out at you?
I'm getting a little concerned about monkeypox.
Yeah.
The other thing is COVID's not going away. So
Yeah. What are the long haul? What's the long haul symptoms going to be? Is it, is it cardiologists? Is it, congestive heart failure? Is it, swelling? Where is it going to go? Is it going to be joints and pain for the rest of your life? So that's kind of a little nerve wracking because we've entered this new world where what are we going to be dealing with in 10 years from now?
right, right. And we don't know. And, I was telling somebody just a couple of days ago, we don't really know at this point if COVID's going to become a seasonal disease or not. The 4 previously common human coronaviruses, 3 of those are seasonal, but one's not really.
Yeah.
So we don't know. I mean, so far, COVID has not shown, well, it has shown, 2 winters in a row, we've had a huge wave, and that's not unexpected. But we've also had some big waves in the summers.
Yeah.
I mean, is it going to settle into a winter pattern? I don't know. I'm not making any predictions at this point.
All right. All right.
Maybe Imani knows. She's an epidemiologist.
Not sure what to expect at this point.
She's a real epidemiologist, not an amateur like me.
It is. If I can go back to being a young high schooler, I would definitely go down that route. It's like so much fun to know, to know that knowledge. I would have totally focused more in that area.
Yeah.
So
Imani, you joined us what, 1 month, 2 months before the pandemic?
January 2020.
Yeah. Good time.
Right. Yeah. Awesome. Well, I cannot connect back to that server. I am more than happy to work one-on-one with anybody. If you have my contact information, you have my cell, you have my email, I'm willing to share it. I answer constantly, daily, day-to-day questions, and I'll just say, hey, let's just jump online. I'll just show you real quick how to do it. I have no problem doing it. A lot of them just take 10, 15 minutes. If you want to schedule a more in-depth, I have tried to call me up all the time, and they're like, hey, can you do a quick 1 hour refresher with our guys? Can you do and we just get 10 people in a room and we just dive in. And, I have it all here, and I want to spread it out and show it to everybody, because these are powerful tools that we can use that really do change healthcare and the quality of life of the communities that we serve. So let's really make that effort. And that's why I'm totally open and totally free and available for you guys. So just let me know. I don't know how to wrap it up. So does anyone want to wrap it up?
Yeah, I'll go ahead. I just want to say a big thank you to you, James, for facilitating our closing RPMS training, and to our attendees for attending today. There is a survey that I have sent to everyone individually and in the group chat. We'd really appreciate for you guys to try to fill it out so we can get feedback to improve in future RPMS trainings. That's it. Thank you guys so much.
All right. Thank you, guys. Good seeing you. Good seeing you again, Dr. Brown.
Good to see you. Get well soon.
Will do.